Welcome to my presentation. I'm going to be talking fast and straight to the point right off the script that I made to make sure I cover all of my bases. Firstly, Chile is a country lining the coast of South America with a population of just under 20 million people. The majority of the population, about 89%, identify as white or non-indigenous. Spanish is the official language spoken by nearly everyone, though about 10% of the population also speaks English. As for religion, Chile is predominantly Roman Catholic, with a growing percentage identifying as evangelical or non-religious. The country is highly urbanized, with over 84% of Chileans living in cities as of 2025. The population also has a median age of nearly 37 years, with literacy very high at over 96%, and the country invests about 5.4% of its gross domestic product into education. While the country saw modest GDP growth of 2.6% in 2024, largely driven by mining exports, investment still declined, and consumption barely grew. Unemployment sits at 8.5%, slightly better than recent years, but still higher than pre-pandemic levels. Poverty remains relatively low at 4.6%, and Chile continues to outperform many countries in income inequality with a GINI index of 43 points. That said, however, economic growth has been sluggish for over a decade and productivity has stagnated. From a public health perspective, Chile maintains a relatively well-resourced system with about 2.6 physicians and 2.1 hospital beds per thousand people. However, access to quality care is often uneven, especially for lower income and rural populations. Public dissatisfaction with inequality and public services boiled over in 2019, leading to nationwide protests that called for systemic reform, including healthcare. Chile has experienced significant political and social turbulence in recent years, specifically referring to the 2019 protests. They erupted over public transport costs and widespread inequality. Police responded to this with excessive force, which resulted in international criticism. Since then, the country has attempted to write a new constitution twice, but voters rejected both proposals. Unfortunately, Chile is currently facing a critical public health challenge in its fight against HIV or AIDS. As of 2023, approximately 91,000 people are living with HIV in Chile, representing 0.7% of the population. This marks an increase from 0.6% in 2020, and Chile now has the highest rate of new HIV cases in Latin America, and one of the top 10 globally in terms of case growth over the past decade. HIV in Chile overwhelmingly affects men, who make up 85% of all cases, or about 77,000 individuals. The primary mode of transmission is homosexual contact, which accounts for over 50% of all cases. Heterosexual contact is the second most common transmission route, responsible for about 30% of new infections. Access to treatment in Chile is relatively strong. Around 97% of people who know their status have access to treatment, and 70% of all people living with HIV are currently receiving antiretroviral therapy, or ARVs. As a result, about 66% of HIV-positive individuals have achieved viral suppression, which greatly reduces the risk of transmitting the virus to others. Chile spends around 206 million USD per year on HIV programs. The majority of this funding, about 130 million, comes from domestic public sources, with the rest coming from private and limited international sources. In addition to public treatment programs, Chile also invests in prevention. For example, more than 31,000 condoms were distributed in prisons as part of targeted HIV prevention programs. Now, despite strong treatment access, Chile's HIV epidemic is growing. The country has seen a 50% increase in new cases over the past decade, and many of these cases occur among young adults aged 15 to 49. The Ministry of Health continues to lead efforts in surveillance, education, and treatment, but rising infection rates point to gaps in prevention. Although Chile has recently recognized same-sex marriage, stigma and discrimination, especially towards LGBTQ+ communities, remains strong. This stigma discourages people from disclosing their HIV status or even seeking testing in the first place. Chile does have important legal protections. For example, HIV testing is voluntary, confidential, and requires informed consent under Article 5 of HIV law in Chile. However, these same protections have also become unintended barriers for early diagnosis, especially in public systems where patients are assigned disease codes, which can feel very stigmatizing. Chile's geography creates another barrier. The country is over 4,000 kilometers long, but HIV diagnosis is centralized to Santiago due to Decree 158/04. This means that samples from northern or southern cities must travel thousands of kilometers to be confirmed and returned. Many patients lose trust in the system during this waiting period and drop out of care entirely. Now, Chile's HIV law obligates the state to promote scientific research and comprehensive prevention, but actual public investment in these areas has been historically very low. There's also a lack of self-administered testing, and critical lab tests like viral loads, CD4 counts, and genotypic resistance testing are only performed in Santiago. This creates logistical issues like damaged or mislabeled samples, delays in care, and perceptions of poor service, all of which lead to treatment abandonment and low adherence. Experts suggest that one major way to improve HIV outcomes in Chile is to implement universal screening, reduce reliance and over-centralized systems, and normalize testing to eliminate the stigma surrounding it. Now, sociologists play a critical role in addressing Chile's HIV and AIDS crisis, not just by studying it, but by shaping better responses to it. First, they help uncover how stigma, cultural attitudes, and institutional barriers affect individuals' willingness to get tested or seek care. By researching healthcare access, urban-rural disparities, and the effects of centralized systems, sociologists can inform policies that help improve equity and care retention. Sociologists also amplify the voices of marginalized communities, including the LGBTQ+ people and indigenous groups, ensuring that public health responses are not just medical but also socially just.